Hello, and thank you for joining us for this virtual institute. We know you have a lot of other opportunities and other demands on your time. I'm going to be speaking with you for the next 30 minutes on accelerating the uptake of evidence and the synergy between implementation and improvement science. Thank you to the COSTAR Committee and Organizing Committee for inviting me here today. My name is Prvu Bettger, and I'm an Associate Professor of Orthopedics and Nursing. I wanted to disclose that I do have leadership positions in our Center for Health Policy and our Clinical and Translational Science Institute, faculty affiliations across campus, and I'm the principal investigator of the Duke Roybal Center with related funding for implementation science in the VA Office of Rural Health, NIDCD, Fogarty, and NHLBI. What we're going to do over the next 30 minutes is first talk about the scientific pathway for translation and how we can see implementation and improvement science coming together in that translation. We'll distinguish between the two and then apply principles from both to be able to address the challenges that we're facing in practice, to be able to accelerate evidence uptake. So take a second and think, what brings you here today? Do you spend more of your time in practice or in research? Are you studying? Are you a decision maker? Bring that lens to this talk this afternoon so that you can take away what's going to be most meaningful for you. When we discuss implementation science, we start from a grounding in evidence. Evidence, as we understand, is strongest from a randomized control trial, and the first published randomized control trial was actually just before 1950 for the treatment of tuberculosis. The expectation from a randomized control trial is that ultimately that intervention, if found efficacious, will improve population health. We know that tuberculosis is still the leading cause of death for infectious disease today. So there's a lot that we have to learn still on how do we translate evidence from a randomized control trial to ultimately improve population health. This is one of many models of moving from ideas to effectiveness. The ORBIT model was developed focusing on behavioral treatments for chronic diseases, and you'll see somewhat of a linear pathway depicted here, moving through intervention development, preliminary testing, ultimately an efficacy trial, and effectiveness research. The National Institutes of Aging in this last round funded several centers so that we focus on an alternative model of behavioral intervention development called the NIH STAGE model. What I like about this model is that you don't see a linear pathway, and this is much more of how the world works, in that there's a lot of back and forth, a lot of moving forward, needing to take a step back to look at things again as we move from those initial questions through intervention development, understanding what works, how it works, and what's going to move it forward to ultimately be implemented. Not linear, not prescriptive, iterative. And an important visual as we move forward, thinking about how do we move the evidence that we know and that guides our practice forward so that it's used broadly to improve health. Wanted to have some standard language for all of us today on the terms that I'll be using. This institute obviously focused on implementation science, and many of you are likely very familiar with the definition of implementation science: scientific study of the development and use of strategies to adopt and integrate evidence-based health interventions. Implementation science is a very behavioral grounded area of research where we look at quality improvement that comes from industry, very pragmatic approach to improvement and change, the systematic and formal approach of analysis of practice performance, and continuous efforts that lead to measurable improvements. More recently, we're seeing the science of quality improvement emerge, where there's been scientific study of how methods, theories, and approaches are used to accelerate improvement. And this is where I wanted to guide our discussion today, to be able to pull together improvement science, implementation science, and the tools from quality improvement so that we can accelerate translation and reach more people with the evidence base that we have in practice today. Some common misconceptions are sometimes shared, and I use this table that was actually published by colleagues of mine in the Journal of Oncology Practice to delineate where there are some shared concepts and approaches between implementation, improvement, and science, where there are some differences, but also how they can be synergistic. As we focus on the left with implementation science, we're talking a lot today and in the next session on promoting systematic uptake of evidence-based interventions, whereas improvement science comes from a systems level framework focused on quality, safety, and value of healthcare. The problems, although here depicted differently, implementation science focused on slow variable evidence uptake, improvement science drills down into what is that dysfunction, but still often related to a gap in practice. Implementation science, as I mentioned, is founded on behavioral change, generalizable mechanisms of change. Improvement science is much more location specific, aiming to improve reliability, but the two do share a focus on processes, people, data, and measurement. Both find and reinforce that context is critical, and both are built at the system level. I'm going to talk about strategies and interventions a little bit in a little bit, but wanted to highlight that in implementation science, we often use that term strategies of how we're moving evidence forward. In improvement science, the same terminology or different terminology is used for a similar area, and they're referred to as interventions. And we'll have some examples of those in a minute. So this is actually what motivated me to begin in this field and beginning to pull these together. It was 2006. I was just finishing my doctorate at Boston University, and the study came out, published in JAMA, on the differences in acute coronary syndrome care at 430 hospitals. So here we are, literally decades after the first beta blocker heart attack trial was published to ground the evidence in beta blockers for treatment, and yet we're still seeing a 20% difference across centers in the United States in delivering that care. Why does that happen? This was just in being able to prescribe the right medication. It didn't even begin to address, did people take it? Did they have access to medications when they went home? What was adherence like? Were they persistent? What were those challenges moving forward? This was just on prescription at hospital discharge. It's really critical for us to think about the data that drives some of the questions that we have. And this is how I want you to think going forward about the opportunities in improvement and in implementation science, because when we look at these data within healthcare systems, we begin to think about, well, what could we be doing differently? How do we close that gap? And we similarly have that question for implementation science, and how can we ultimately improve uptake of what we know should be happening in practice. So this statistic is likely not unfamiliar to many of you, that it takes 17 years to move findings from a clinical trial into practice. And even then, it only reaches 14% of the population intended to receive it. It was also in that same time period as I was finishing my own doctoral studies, when these data came out, that with targeted implementation and a team focused on effective use and implementation and integration of appropriate tools and practice, we can actually accelerate uptake from 17 years to 3 years and reach 80% of the population. This was back in 2007. And that's why I bring these frameworks together for you today. On the left, the conceptual model of implementation research we've seen already today, and for some of you who have attended in years past, hoping this is becoming more familiar to you. For those of you where this is new, on the far left, you see the box of what we should be implementing. So what has already been found to work and with which populations. And that moves us all the way to the far right on improving what outcomes. It's critical to understand that foundation, what intervention and improving what outcomes. The core of implementation science lands in this shaded box in the middle, where we begin to identify what strategies, how we're addressing which implementation outcomes, and we've already discussed those today, how those influence service outcomes to ultimately influence health outcomes. The reason why the model for improvement fits so well in here is that, as you see at the top of the model for improvement, and this is just one model of many that could be used in improvement science. I happen to like this one from the Institute for Healthcare Improvement, not only because of its fit, because it also is very direct and specific in that, first, identifying what we're trying to accomplish. So this is a critical question. We'll begin to think about, what is that question? Where is that gap? And sometimes I find that we'll go into an area of implementation science without clearly knowing what is the gap in practice. And this, in quality improvement and improvement science, is our first question. What are we trying to accomplish? Second, how will we know that a change is an improvement? This second question in improvement science really gets to measurement. So what is going to be the very specific area of measurement that we can focus on to know that change is happening, that evidence is moving forward and is reaching more people? And lastly, what changes can we make that will result in improvement? This is the alignment with the question for implementation strategies, our interventions, as we would call them in improvement science, or implementation strategies and implementation research. So the alignment here is critical, because the arrows in the implementation science framework between the left red box and the right red box ultimately, as you see, don't go in just one direction, because it takes iterative change and improvement and learning. And this is where we have the opportunity to add in these plan, do, study, act, or continuous improvement or iterative cycles of change, so that we test a strategy, look at how that may impact, whether it's penetration or acceptability, go back and revise, and then look again at our data. And that back and forth is an opportunity for us to think about, how do we learn from iterative change? How do we embed iterative change in our research framework so that we have stronger implementation outcomes, so that we have better service outcomes and ultimately better health? Context matters. And I think we recognize this in both areas of implementation and improvement science. And I want to guide you through how we are looking at this from both frameworks and how this can come together. In improvement science, we often start with data, where we look at variations in practice, because variation can be extremely informative. What you hear and what you see here on the screen, every blue line could be a different therapist, could be a different clinic, could be a different hospital, could be a different region. Depending on what your unit of analysis is, each line is independent. And by lining them together from lowest uptake to highest uptake, we begin to see that some are doing pretty well. What can we learn from them? What can they teach us? Some aren't doing as well. Performance is much lower. Are they doing something different? Have they not yet started certain things? What things do they not have in place? These data, just visually, already begin to drive questions that we also ask in implementation research. So on the right-hand side, you'll see some familiar implementation science language: consolidated framework, implementation strategies. The mix of arrows here are going to guide you through how we can integrate improvement in implementation science. As I just showed you, learning what the current state of practice is critical. If we're aiming for evidence uptake, really spend the time to understand where practice is today. That last chart was comparative ranking. You could also use control charts, which are very common in healthcare practice, to be able to show variation over time. With these data, you can then move forward and talk with your teams, and this is critical, talk with your teams on what is leading to variation. I asked the question in the last slide about what might be different between organizations, but even within one site at a time, using tools from improvement science such as root cause analysis, 5 whys, a fishbone or Ishikawa diagram, spending time to observe practice, or even developing a Pareto chart can help understand how the different strategies or interventions, current practice is associated with the current state. With these data, you're also, in working with these data, you're also building a team, and you're going to hear about the value of stakeholders in the next session. So now you have a team, you have some initial thoughts about why we're seeing the gaps that we are, and then you can move forward together to look at, for example, the Consolidated Framework for Implementation Research. CFR, as many of you refer to the framework, is a framework with 5 clear domains and several items within each. They help provide context. They help identify particular areas where there may be barriers or strong facilitators. It's important to use this as an area or discussion tool to be able to identify which you'd want to look at further. It's quite expansive. Not all of the areas may apply, but together with some of your early discussions, you may identify specific things that you'd like to look at further to describe the context. You now have information on barriers, potential root causes, and how do you begin to move forward in thinking about what you might begin to test. There are tools to move directly from the consolidated framework to implementation strategies. We'll talk about those briefly, and some you have already likely been exposed to, like the C4ERIC matching tool. In improvement science, we would bring these data back to a group and begin to brainstorm. Use tools like an affinity diagram, or even go through a nominal group technique or prioritization matrix to have ideas laid out, begin voting, whether it's weighted voting in the nominal group technique or otherwise, and come to consensus on how we might begin, what could be feasible, what best fits our setting and our resources. This discussion, when happening across multiple sites, or if in one site, and ideally you're planning for long-term and widespread implementation and scale, you could then bring in other sites for additional information and their feedback. Would it fit here? What might we test? What's most important in our setting? By looking out beyond your own setting, which is very common in improvement science, and thinking beyond where you practice and getting that information, you're helping build generalizable foundation for future research. And as I mentioned, coming together to define those strategies is critical for is a critical step that we do with stakeholders. There are many categories of implementation strategies that you may consider with your teams. Your teams may have identified others that map into these frameworks. On the left, you see the behavior change technique taxonomy. This is even available as an app on your phone. There are 93 clustered techniques in this version 1. Different ways to consider behavior change, from checklists to there are over 20 different strategies related to financing and behavioral economics. A lot of different things you might want to consider for social support, for the engagement of others. On the right-hand side, many of you are likely familiar with the ERIC strategies published with 73 categories for implementing change. A lot of opportunities, a lot of areas to discuss, and which ones are going to be best fit for your situation will depend on the involvement of your team, your data, and that includes your quantitative and your qualitative data at individual provider and system levels. Here are some useful resources to move from context to strategies. As I mentioned, there are the mapping tool. The Query Implementation Network has some guidance. There are additional taxonomies and intervention mapping approaches published that you may want to consider. But what I want to focus on next is how you can be looking ahead from where you are, taking each step with broad uptake in mind. This is often the area where people then divide implementation and improvement science, many concluding that improvement science is only within a single setting for a single provider group at a local area. If we plan our science and our research to be able to be generalizable or to guide scale, then that's our opportunity to ultimately improve uptake and improve population health. I want to use the example that's facing many of us today with telerehabilitation. As I mentioned and started this presentation today, it takes 17 years on average to get evidence into practice and only reach 14% of the population. If we look maybe even till last December on where the evidence was for video-enabled visits, for virtual rehabilitation, we had a long way to go, many populations to test with, a lot to learn. But here we are in the era of COVID, rapidly scaling many different forms of telerehabilitation. So in the middle, what we see is the diffusion of innovation curve. In your institution, your teams could be anywhere along this, depending on where you were as we headed into this pandemic. The chasm, as defined there, is a critical leaping point that for some institutions that may have started even before the pandemic and rolling out telehealth or telerehabilitation with their patients, they may have actually had this implemented with 15% of their providers, maybe reaching about 10 to 20% of their population, patient population. But what did it take to move them forward? Where were they able to make that leap into reaching more patients and having more providers implement? It's critical to understand what that leap looks like. And this is why it is our opportunity today to integrate improvement science and implementation science. You are all, those of you in practice, rapidly implementing. And if we wrap around our implementation science questions and frameworks with the strategies to be looking closely at data every week, what are we doing differently? Who are we reaching? What is working? What isn't? How do we change it for the week ahead? We will build the evidence we need so that the evidence for telerehabilitation will reach 80% of the population within 3 years, rather than the findings we had seen up to today. I really like this diagram from Amy Abernathy with the FDA, where she reminds us it's important to take time to develop an intervention, that phase 1. And it is important to test it in a clinical trial and understand what the effect is. When we know that it could benefit patients or help and improve a system, we need to think about pragmatic implementation effectiveness research with continuous assessment and refinement, integrating these PDSA cycles so that ultimately we have wide-scale tests of change that are implemented and sustained in practice. Lastly, I want to leave you with the Institute for Healthcare Improvement Scale-Up Framework, very relevant again to this focus on telerehabilitation today, where we are literally building evidence as we're implementing. And this is where we consider the best practice that exists and the new ideas that are coming to bear in this pandemic. How were they set up? Define what your scalable unit is and look at how it works. Notice the arrows on the top. It's important that while we're implementing, we understand what could be revised, go back to your scalable unit, how was it packaged, and then test again. These ideas of a test don't need to necessarily be in the framework of research. Use your data to guide what those tests are. A test may be 1 day, it may be 1 week, it may be 5 patients, whatever that test is. In improvement science, we often discuss scale being from 1 to 5 to 25 to 125. But what is your unit of analysis? What do you need to go full scale? How many providers do you have? How many patients do you have? Think about what your phases of scale up are. Were you able to reach what you intended over these last 2 months that we've been home and providing essential services for many remotely? And our opportunity to study what was being provided, the content, what were those adoption mechanisms, and what are our supports? With these data, we will move practice forward faster than over 17 years. And it will take both improvement and implementation research to help us get through in establishing evidence in practice and building our health systems to be learning health systems that can guide the future. Thank you so much for having me here today, and I hope we have a robust discussion for the rest of the afternoon. I want to thank all of you in every role that you have and you occupy, either as healthcare workers, essential employees in any area. Some of you may be policymakers, family caregivers, and to those staying at home. Thank you. Please let me know if I can answer any other questions.